Good morning. I am Jenifer Lightdale from Children's Hospital Boston, and I am an associate editor for gastrointestinal endoscopy. And it is a great pleasure to be here today with my friend and colleague, Dr. John Saltzman, who has authored a study entitled "A Simple Risk Score Accurately Predicts In-Hospital Mortality, Length of Stay, and Cost in Acute Upper GI Bleeding." John, great to see you. So how did you get the idea for this study, and what were you trying to do? What was the background?
Well, as you know, GI bleeding still has a high mortality of somewhere between 3 and 15%. And it is those patients who have further bleeding that have a high mortality. So about 80% of patients will stop bleeding spontaneously. They generally do well. The 20% who bleed more are at risk for mortality. And at this point, one of the goals of treatment is to figure out who's at higher risk for bad outcomes, who's going to rebleed, who's going to have a higher mortality. And there's been a lot of interest in this field, and there's been already several risk scores that have been developed. A consensus conference on GI bleeding in 2010 that was published in the Annals of Internal Medicine recommended that risk score prognostic scores be used for the management of upper GI bleeders, with the hope that we could tell patients that are high risk and sort them out from the low risk, direct our resources to the high risk, and let the patients who are low risk go home early. The problem is people are not using these scales. So we wanted to look into whether a new scale that was simpler there may be room for.
Okay, so the goal was really to find a simpler scale, too.
Yeah, so one of the things was simpler. The other thing is that the major scales that are out there have been all derived and validated in non-U.S. populations. So I was interested to know whether these scales would be valid in a U.S. population, or would we come up with the same risk factors as these other scales.
Okay, so what was the methodology used? How did you design your study?
So we had access to a database from the state of Pennsylvania that was a really wonderful and powerful database. We were able to include 187 hospitals in this database, and these hospitals represented both urban hospitals, rural hospitals, teaching hospitals, non-teaching hospitals, small, medium, and large hospitals. So we thought it was a really good cross-section. And we had a large number of patients. So what we did is we did a derivation of the score in 2004-2005 data, where we had over 29,000 bleeders who were in this database. Now that's a lot of bleeders. That's about 10 times as big as most of the other large studies that have done this. And then we used a technique called recursive partitioning, where what we did is we took our candidate variables. We had about 30 variables that we could look at with such a large population that were plausible indicators or risk factors for further bleeding, and we were able to separate which is the most important risk factor and what are the other most important risk factors there. So we were able to go through it, and then once we were able to derive our score, we were able to look at a different set of years, another 2 years, 2006, 2007, and then we were able to validate that within the same population. In that 2-year period, we had 32,000 GI bleeders.
Wow.
So it's a lot of bleeders.
And what did you find? What were your predictor variables?
So the main outcomes of the study, so their goal was to look at mortality as the primary endpoint, and the secondary endpoints were looking at length of stay and hospital costs.
Can I ask you a question there?
Sure.
You didn't look at rebleeding.
Right. We did not look at rebleeding because the administrative database that we used did not have the detail to actually measure rebleeding. I would have loved to look at rebleeding, but was just not available. On the other hand, the administrative database did have other variables in it that are not commonly in databases, such as initial signs in the emergency department. So it had questions that people were asked, physical exam signs in the emergency department that were available in this database. And what we found were 5 variables that were most predictive. And we were calling this risk prognostic score the AIM-65, so we can remember this.
Okay.
So
the AIM-65, okay.
Let's see if I can remember this. So A is albumin, and an albumin of less than 3.0 was predictive. I is INR, and an INR of greater than 1.5 was predictive. AIM is mental status change. So if somebody had a mental status change in the emergency department, that was predictive. S is blood pressure. Blood pressure of 90 or less was predictive, and then the 65 is age. So age of over 65 was predictive. So those 5 variables were predictive. And what we found was that they were additive. And unlike some of the other scores, it was just a simple, each factor was counted for 1. And so you have a risk score of 0 through 5, where 5 would be the highest risk factor. And if you had a score of 0, your mortality risk was 0.3% in both the derivation and validation, where if you had 5, your risk was somewhere between 25 and 32%, and it just walked up. It seemed to be very predictive.
Okay.
And the length of stays also walked up with the number of variables, as did the costs.
Okay, so do you think it's ready for prime time? Should we be using it in the emergency room?
Well, I think it's a very promising scale. It does offer, compared to the other ones that are out there right now, a very simple prognostic scale. So the main 2 that are been used now are the Rock-Hall score, and the Rock-Hall score requires, in addition to information in the emergency department, endoscopy information included. So you have to wait till your endoscopy to fully calculate it, and it's a weighted score, so things have a value of 0, 1, 2, or 3. And the Blatchford, which is more similar to our risk score, which uses only information available in the emergency department, but also it's a weighted scale, so it's not easy to remember. So this is an easier to remember scale, but the next step of this is to take this score, to put it into a different population than it was derived and validated in, and compare it directly to scores such as the modified Blatchford, and look at outcomes such as rebleeding that you asked me, and say, well, how does this do compared to mortality, and how does this do to rebleeding and other important outcomes?
Okay. All right. It sounds very exciting, and we'll wish you luck in the future studies as you go forward.
Well, thank you. I appreciate the opportunity to talk about my study today.